Again, welcome you to the Myositis Association's Ask the Doc. We do this webinar series monthly. My name is Chrissy Thornton. I'm the Executive Director. And I'm so happy to share tonight with you as another example of how the Myositis Association is committed to providing education and resources for our patient community. COVID pandemic exposed to us just how useful the virtual environment could be. And we are so excited and appreciative and grateful to all of our medical advisory board members who have participated in this forum this year and allowed us to have continuous education each and every month to be able to offer increased opportunity and access to some of the world's leading scientists, researchers, and most caring and compassionate clinicians. So tonight is no different. Tonight we have with us our medical advisory board member, Dr. Lindsay Alfano. And Dr. Lindsay Alfano is a physical therapist with expertise in the care and evaluation of patients with neuromuscular disease, including outcome measure development, evaluation, and administration. She plays an integral role in planning and designing clinical trials and contributes to protocol development, outcome measure selection, statistical analysis, and interpretation for ongoing clinical trials. Dr. Alfano serves on an international consortium of neuromuscular physical therapy experts that provide industry standard training and reliability for multi-site international trials. Her research goals focus on standardizing training in rare disease, as well as developing and promoting optimal assessment tools to measure change in movement abilities while minimizing the burden of testing. She has co-developed novel outcomes, including the active and active mini systems, 100-meter time test, and the neuromuscular gross motor outcome. In response to the COVID-19 pandemic, Dr. Alfano and the physical therapy team at Nationwide Children's Hospital have led initiatives to understand and validate remote testing for patients with neuromuscular diseases for clinical and research purposes. Tonight, we are happy to welcome our very own medical advisory board member, Dr. Lindsay Alfano, and you will have the opportunity after her presentation to ask questions that you can put into the Q&A section of the webinar Zoom platform. Without further ado, I'd like to welcome Dr. Lindsay Alfano.
Wonderful, thank you so much. To shorten my introduction, that's gets very wordy, but yeah, thank you. That was fantastic. I'm really excited to be with you all today. I do think that we here at Nationwide Children's Hospital, don't be confused, although the word children's is there, we do see patients from birth through adulthood with progressive neuromuscular disorders. And so I think we do have kind of the coolest job where we get to see patients in clinic. We also get to do research to help answer your questions and our own questions. And so I'm going to share a little bit about what we do with you this evening. And then I'm really excited to take your questions, so don't be shy. If I can't answer them, we will get the answers for you. All right, so can you see my screen, Chrissy? All right. It always works until it needs to, so I'm glad it's continuing to work. So just as kind of a refresher, my position kind of has three roles. So I do see patients in our neuromuscular clinic. I also do a lot of training for industry-sponsored trials to make sure that everyone is doing assessments in the same way. We want to make sure that we're consistent so that we don't have variability in our assessments, so that if a treatment works, we can measure that. And I'll talk a little bit more about that later. And then as Chrissy said in that lovely introduction, I'm really interested in novel outcome development. I think we have a lot of great options, but hearing from patients, I'm not sure we've reached the optimal outcomes for many of our patient groups. So I think there's a lot for us to continue to learn. And I do think sometimes we measure things just because we can. And so I think we can find ways to reduce the burden of testing for patients. And so that's kind of our goal. So I did want to talk about outcomes a bit because I think I get a lot of questions from patients about why we do the different tests that we do as physical therapists. We do like to measure things, but we hope that that measurement is actually useful for you as well. So we do collect outcomes for both clinical and research purposes, but you'll see kind of at the bottom of the slide, I do think clinic bleeds into research, research informs clinic. And so I do see it as kind of this circular process where we're continuing to learn and improve standards of care and our understanding of disease. So we do use outcomes to guide decision-making throughout the diagnostic process. So we work as part of that multidisciplinary team. I find that the more data we collect, the more we can give you kind of data-driven answers about whether disease is following an expected trajectory, or maybe something progressing less slowly or more quickly, and we can figure out why that's happening sometimes. We can also proactively plan for supports that are needed rather than you having to track us down and say, look, this is getting really hard, I need something. We can get you those things you need before it's urgent. And then the goal is really to have data-driven answers. So it does no good to you if I just say, oh, you look about the same, that's great. Need anything from me? We want to have those discussions often as part of our evaluations. I'm asking questions that patients may not have thought of in the specific way that I'm asking. So we can have really rich discussions and make sure that we're meeting all of your needs. From a clinical trial purpose, these outcomes really help us understand progression of a disorder, what systems different diagnoses can impact. I think one of the harder discussions that we have with patients is, this X, Y, or Z has happened to me. Is this related to myositis, or is this just me? And so the more information we have, the more measurements we have, we can answer that question sometimes. Not always right away, but we get there. We also can figure out what's meaningful change. So thinking about it in the context of a potential treatment, if you walk 3 meters further, is that really meaningful? Or if you gain 1 point, what is that meaningfulness? We also use this to really build our team. So we're building a relationship and trust between you, the multidisciplinary team. We're hearing from you. So these clinic visits are really meaningful from our perspective, and hopefully you get as much out of them as we do. So I know we always get a lot of questions about clinical trials, and since I measure things, I do like to always start with, why do we need to do a clinical trial? Why do we need to do a natural history study before a clinical trial? Why can't we just jump to the clinical trial? And I think this picture really helps. It says more words than I can, I suppose, that, we're not all the same. Outcomes are different. People are different. What we ask you to do, for one person may not be meaningful for another. So we have a lot of factors we're considering when we're thinking about, what should we be using to measure your function or your swallowing or your breathing. There's your own set of variables. So tests we use in a pediatric population, we wouldn't necessarily use in an adult population. There's variability in your own performance from day to day, and we need to kind of understand what that looks like. The study or the reason we're doing these measurements is really important. So are we looking to measure an improvement, or maybe just maintenance of function, which is really important? And then our outcomes themselves have a lot of different internal factors that we're measuring. But the goal is to find that signal through the noise. And so the more, if you participate in natural history studies, our goal is really to pick that optimal outcome for the future trial that comes, so that we can be kind of data driven in our design of a study, and we don't get to the end of the trial and think, did that work or did it not work? Or maybe a treatment, worked a little bit. We want to make sure that we don't throw the baby out with the bathwater. So some of the research that we've done, I wanted to highlight one of the studies that we've done in, response to the pandemic, is validating remote outcomes, or us assessing patients within the home environment, which is something we didn't really do at all before the pandemic, to be honest. So this has been in collaboration with the Cure VCP disease organization. It is in patients that have variants in VCP gene, which is not a myositis, but they do have inclusion body myopathy, just not that inflammatory component. But some of the learnings that we're we're gathering from this patient population can also be used to benefit other patient populations. So it's not, I guess, diagnosis specific. So we've been able to enroll a bunch of patients to come to our clinic across the US. We're trying to understand how different functional outcomes work in our clinic environment, and then how those function in the home environment. So patients have been doing both those home visits and on-site visits. We did, because the remote visits are going so well, we opened a remote only cohort. So we've been able to see patients in Brazil and Australia, and it's great to, again, see patients where they are. We're also continuing to follow them over time. This next slide is really busy, but this is the list of things that we're evaluating. So you'll see we have some walking tests, we have some arm tests, we have some breathing tests. We're also asking patients a lot of questions about how this disease could impact them. And this is really common for a natural history study, where we're trying to figure out what outcomes work and in which patient groups do these work. So I'll cut to the chase. There are pros and cons of remote testing, but the good news is I do think it is completely feasible to do some outcomes in the home environment if they're done correctly. So we do have really what we call high test retest reliability, which means if we test you on day one and then test you the next day, your scores or your times or your abilities are about the same. One of my biggest concerns in doing these remote visits is, when patients are in our clinic environment, I'm there and I can keep patients safe, but in the home, I have less control. So we were really worried about safety in that home environment. And I'm happy to say that we've had no falls, no injuries. All of our testing has been able to be done in a safe way. And then surprisingly, or happily, I guess, we do have some pretty good reliability between the scores we get in our clinic environment that we see in the home environment. The negatives are we can't do everything in the home that we can do in the clinic. So some outcomes just aren't feasible. We have some where you have a long 25-meter track, and most homes don't have, a football field in the house. It's nice to have a family member or caregiver available just for safety purposes to help with some of the assessments if needed. And they're not always available as we are when we're in the clinic and you come to see us. We do have a little bit more variability in some of the outcomes that is mostly related to just the standardized equipment, like a chair height. It's easier to get out of a taller chair, harder to get out of lower chairs, and our chair heights between clinic and home are different. We're still looking at these outcomes over time, but I do think that remote testing is likely to be part of some trials in the future. When, I can't say, but I do think they are feasible. I wanted to switch. My last kind of topic is just to talk about exercise and activity, which I think is where I get a lot of questions from patients. And I bet we'll have a few questions about this today. So don't hesitate to put your questions in the Q&A. I think there is, often when we think about exercise, we think about going to the gym and lifting weights and doing those sorts of things. It's targeted, you're doing a specific regimen, 3 sets of 10. They're designed to, build or improve your strength, often supervised. You might have a personal trainer, versus activity is more of a general movement. I want to highlight with this slide that exercise and activity do overlap. So you can absolutely do exercise with your typical daily activities. So you don't have to have a gym membership. You don't have to have a personal trainer. You can have people that give you home exercise programs or kind of coach you along. But it doesn't have to be a formal regimen to keep your body moving and keep yourself active. So this slide highlights all of the work that has been done to show that exercise and activity are absolutely beneficial in myositis. So we do want patients to be active. We do want you to find a safe way to exercise. We know that muscle is there, and if you don't use it, you will lose it. But it's finding that balance. So how do I do it? How do I get started? I think if it's been a while since you have done exercise and activity, it's always a good idea to find a local PT to help you get started. Here on this slide, I have the American Physical Therapy Association has a link where you can find a PT in your area that may have different expertise or certifications, where they may be better at sports PT, or some are better in or certified and specialists in kind of the neurologic disorders. It's always important. So the other disclaimer is, make sure before you start an exercise and activity program that you do talk with your physician and your multidisciplinary team to make sure you are doing safe activity. But I often have conversations with patients about, I went to a PT, but they just didn't know about my myositis. So it wasn't a great use of time. In rare disorders, it is really hard to find a local expert in your specific condition or diagnosis. However, it is absolutely possible to find a local PT that is an expert in exercise and movement, and you can make a great team with that person. So you are the expert in you know your body. They are the expert in finding ways to make exercise and activity safe for you. If you have someone that's not open to learning, or maybe is pushing you in directions that you don't feel comfortable, that's not a good team member. So you can find another PT. But putting that team together it has been the best recipe for success. It's always great to have a PT update your home exercise program, so you don't have to go to PT every week forever. We often recommend an episodic model of care, where you check in with a PT for a few sessions, get that program together where you feel safe. You've got a lot of activities you can do at home, and then you go off and live your life and do your activities. If things become harder or easier, you can pop back in for a few sessions and get some updates. The best way to be successful with exercise and have a program that lasts forever is finding something you enjoy doing. So if you do not enjoy walking or riding a bike or playing tennis, that should not be the exercise or activity that you do. We do talk with patients in clinic who are unable to walk, and they say, well, I can't walk, so I can't exercise. That's not true. There are many activities that you can do that do not involve walking. Water-based activities are great. I know not everyone has access to a pool. Taking walks in your power chair is often exercise if you're on uneven terrain, or you're moving, around corners, navigating crowds and things. All movement that you're doing is activity. There are often some sports leagues and things for patients who enjoy. They have like soccer leagues and different outdoor activities. So you can find adapted sports and activity groups to join that keep you moving in a way that's safe for you. The recommended activity, intensity is 30 minutes a day or 150 minutes a week, which is hard to fit into a schedule. So start with an amount of activity that's reasonable for you, and then build up to that level that continues to be reasonable for you. But the caveat is, make sure you're not doing too much. Give your body time to rest. Listen to your body. All of us doing exercise and activity, we're working our muscles. If you get to a point where you're having extreme fatigue or pain, then that's likely an indication you've done too much. So you should scale it back and consult your local team if these sorts of things occur. Be patient with yourself, because everyone has good days and bad days. Some days you can do way more than others, and that's okay. That's completely fine. Also, listen to your family and friends. Sometimes they notice subtle changes that you may not. So make sure that you're, again, building that team. And then energy conservation is the last topic I wanted to talk about. Thinking about community fun days, or days where you may overexert yourself. Think of your body as a fuel tank. So you only have so much energy. As you're moving, you're depleting your energy store. Some activities may be more or less draining than others. Give your body time to rest. If you're going to be doing something that you know is going to be strenuous, think about ways to build rest breaks into that so that you can still participate, but you're not depleting your energy tank. So for example, a lot of our patients that may have decreased endurance with walking long distances will bring transport chairs so that they can sit and rest while they're getting to whatever that event is. And when they're there, they can move around and do what they want, and they're not exhausted. having those devices and equipment is really helpful. Just because you have it doesn't mean you have to use it. They're there to support you when you need it. It's better to have it and not need it than need it and not have it. So with that, I will pause, I guess, and open it up for any questions that have come in or questions that were previously submitted.
Thank you so much, Dr. Alfano. We will, if you stop sharing your screen, we'll come and we'll start taking the questions for tonight. We have some, as you stated, that had come in advance of tonight's webinar, and we encourage all of our live participants to use the Q&A to ask your questions, and we'll do our best to get to them during our time. So the first question might seem pretty simple, but there are people who may need an explanation. What is the difference between physical therapy and occupational therapy?
That is a great question. I was just talking to a patient about that yesterday, actually. So I'd say there is a lot of overlap in PT and OT. Physical therapy tends to focus on more gross motor activities. So, walking, transfers, equipment. Occupational therapy often focuses on more activities of daily living. So dressing, grooming, toileting, those sorts of things. That's not to say that we don't talk to patients about equipment that could help them in the bathroom or, getting dressed in the morning, but that tends to be how the two disciplines kind of divide. Different institutions often sometimes oversimplify, and OT does the arms and PT worries about the legs. So you may hear that as well. But really we work together as a team to make sure that patients are able to be as independent and functional as possible.
Thank you. Is there a specific qualification or type of certification we should be looking for in a physical therapist?
That's a great question. So I'll say the physical therapy field has changed over time. So more recently, you will notice that physical therapists have a doctor of physical therapy degree. That just really indicates kind of when they became a physical therapist. PTs have the opportunity to go for a board certification similar to physicians. So for example, I'm a pediatric certified specialist, so I'll have a PCS after my name. Those that are orthopedic specialists will have an OCS. Those that specialize in neurologic disorders have an NCS. So if you are on the APTA website, you can actually search for experts based on a specific certification in your local area, which is really helpful.
Okay. I love what you said earlier about the patient being the expert on the disease and the professional being the expert on the protocol of that discipline. But the question here is, why don't more physical therapists know about myositis?
That is a great question. I'd say it goes back to education. So I think, again, physical therapy as a field is changing. Historically, we've been very orthopedic focused. So you have a hip replacement or a knee replacement, you go to PT for a bout. And so that's been kind of the bread and butter, so to speak, of a physical therapist's career. In recent years, there have been much more research into neurological injuries such as stroke and Parkinson's and spinal cord injury and those sorts of things. I'd say the neuromuscular research field is very new. So when I first started this position in 2010, I had very minimal neuromuscular training, and really it was check out the website or look for patient organizations. I think this is changing, but it does take time to build that education base. So many physical therapists that were educated pre-2010 may not have had a lot of training in neuromuscular disorders.
I have a desk cycle. Is it better to go longer with easier or shorter, or with more difficult? Okay. What should I add to this to improve going upstairs, which is the goal? I usually ride for about 30 minutes, 6 days a week.
Yeah, so that is a great question. What we like is if you're able to get your heart rate up enough to get both muscle activity as well as cardiovascular benefits. So, if you're able to tolerate an intensity, I think probably with the more difficult, that's what we're looking for. If you're able to tolerate a higher intensity where you are getting an increased heart rate for 30 minutes, that would be delightful. If that is too much, then I think you could do longer with less intensity. But really that sweet spot is getting both your muscles moving and getting some cardiovascular health benefits.
Okay. I was discharged from the hospital diagnosed with saddle pulmonary embolism, diastolic heart failure, along with several years history of polymyositis. I have asthma, COPD. I'm having difficulty being able to move around the way I could prior to hospital admission. My upper leg muscles in the myositis sites are heavily affected. I have walked with a rollator for several years. It's becoming extremely difficult. What are the suggestions you have that might help me?
So after a period of hospitalization and reduced mobility, this often happens. I will say my bias as a physical therapist is to have a bout of physical therapy after you've had an illness that's impacted your mobility. There are individualized ways to figure out which exercises your body can do to build strength as you're able in a safe way. But we often recommend going to physical therapy because there's not a kind of a magic packet of exercises that will work for everyone. So it is really working with where your body is right now and finding things that challenge you in that perfect amount so that you can build strength without being overly fatigued.
What happens in a typical physical therapy session? And what if the exercises are causing soreness?
Great question. So every physical therapy session may be a little bit different. It's really important that you're working on a functional goal. So often, in the US where we have insurance and payers, they're looking to see that you're working toward a goal versus just trying to build strength or maintain ability. So if there is something that's gotten harder, as in the last example where walking with the walker has become increasingly challenging, setting a goal with your physical therapist to work on walking a certain distance or whatever that specific meaningful goal is for you. The activities could involve specific strengthening activities or exercises. You could practice transfers or other things that work your muscles functionally. Sometimes you'll do some stretches if there are muscles that are really tight that are limiting the ability for your body to move in the way that it needs to. What insurance doesn't like to cover is just going to physical therapy to do stretches. They'll let you go to get kind of a home exercise program that you can keep up with at your own home. But going for those sorts of unskilled activities is what they consider them. Those sort of maintenance activities is not typically what they fund.
What are your thoughts on blood flow restriction exercise?
We had a lot of great discussion around this at the myositis meeting this year. So I think there are some patients that were at the meeting that reported some great improvements in strength after doing some of these or participating in these studies or working with a physical therapist to do this safely. I do think there's still a lot to learn about which patients this may or may not work for. It is hard to use that modality for global strengthening because you are restricting blood flow to a specific muscle group. So I think if, again, building that team, I think it's great to find a physical therapist that's willing to work with you. You can try, that activity, but we want to make sure that it's safe and monitored. So it's not something that I would just try because we don't have a lot of research yet to say this specifically the regimen that will work well.
It's increasingly hard to leave home and travel. How do you get approved for physical therapy in the home?
Good question. This, not to sound overly general in my answer, but does depend a lot on your local regulations, your payers, and the institutions around you. So everybody has different requirements for home health PT. A lot of times those are based on medical fragility. So if it's unsafe for you to leave the home, there can be a case made that you need home health services. If you are able to leave the home safely, then often you will be encouraged to do outpatient PT. But if it's something that you are interested in having a home health PT come to your home, then you can always have an evaluation and a discussion about, for that particular agency or institution or your local region or your payer, what are the criteria to be able to do that on a regular basis.
We have a couple of clinical trial focused questions. The first is there anything hopeful on the horizon as far as clinical trials in myositis for IBM patients?
Great question. I like to say there are always hopeful things. Right now, I think one of the best initiatives is led by Dr. Mosafar out of UC Irvine with a multi-site natural history study where that consortium is prospectively looking at outcomes to be ready for future clinical trials. I'd say the landscape is changing constantly. The pace is not always what any of us would want it to be. So it does take a long time to get great ideas into a clinic, again, because we want to make sure that those future potential treatments are safe. Nothing slows progress like adverse events and serious adverse events. I think the Myositis Association is a great resource for getting updates, as well as the clinicaltrials.gov website. You can always search by your diagnosis or other different companies. You can search for all kinds of keywords, and that's the best place to find information about any trial that may be recruiting in your area or in the US, and sometimes abroad.
This question asks, do the outcome measures used in myositis clinical trials meet the FDA's requirements for approval of drugs and blood products?
Ooh, that's a fun question. So that is a fun question. So this is recorded, so I'll be politically correct. So there are lots of discussions. There are always lots of discussions with the FDA about, what is a suitable outcome. I think as the field continues to grow, what that threshold or what the FDA is looking for may shift. So outcomes that, they are really supportive of today may shift 10 years from now, 5 years from now, 2 years from now, as we continue to see how those outcomes are working in clinical trials. This is where participation in those natural history studies is really key, because the more information we have before an investigator or a pharmaceutical company has to sit in front of the FDA and justify their choice, the better off and the quicker that we'll get to that clinical trial. I will say some of the outcomes that are used currently have been accepted by the FDA for trials that have happened in the past and are currently happening. So I would say in general, yes, but there's always room for improvement and more knowledge gained, I suppose.
Thank you.
Mm-hmm.
This asks, can a patient with amyopathic or hypomyopathic DM develop hip pains, instability, joint issues, and pelvic floor problems due to DM without upper thigh weakness? Or would these issues be considered unrelated to dermatomyositis?
Great question. So I'm going to refer you to your local team. However, I will say this does get to the discussion that we often have with patients is sometimes yes, the answer is yes, that those factors can be associated with it, whether it's specifically associated with the disease process or with the amount of activity that you're doing and fatigue and, ligaments get tired and taxed. That's something that you can kind of work through that thought process and problem solving with your local team, because sometimes it is just your body and it's not related to DM, and sometimes it can be something that's related to the disease process.
I am having currently severe neck weakness due to DM. I have been sleeping in a chair since March, since I'm unable to lay flat due to the weakness in my neck, which is uncomfortable when I sleep. What exercises can be done to strengthen the neck muscles?
Yeah, so that is a good question. So I will say there are activities that can be done. Thinking about my slide where I was discussing exercise and activity. So anytime you're moving your muscles, you have the potential to be doing an exercise. So if simply moving your head in different directions, side to side, is taxing on your neck muscles, that may be an exercise. It is some of the discussion that we have with families and patients is about, building strength, but also finding ways to support weak muscles. So, we know that moving muscles, working on strengthening can work to a point, but sometimes just having supports in place can really improve function even more than some of those activities. So again, I'll refer you to your local team to find that sweet spot for you.
Is it possible to rebuild muscle mass and to gain lost weight?
So I will assume that's related to loss of muscle mass being the cause of the loss of weight. I think the easy answer is yes, in general. It is possible to gain muscle mass. The amount of, I guess, what the capacity for your individual muscles to gain is different in everyone, and it really depends on a lot of factors. But that is why we suggest, maintaining that level of exercise and activity that's safe to keep your muscles or get your muscles back up to their optimal size, I guess, and ability.
Can we talk a little bit about water therapy? I know at the recent Myositis annual patient conference, we did hold a session, and I personally spoke to one of our attendees who participated in aqua therapy for the first time, learned some of the techniques with our facilitator, and then participated. And he was an IBM patient who indicated that for the first time since his decline started, he literally felt like when he was in the water, did not have myositis. He felt like he was fully functional. And it was an aha moment for him that even in that short period of time, he actually came home from the conference and started to participate in aqua therapy at home. So can you talk a little bit about the benefits of it and who it's most meant for and who it's safe for?
Absolutely. So I said I wouldn't be specific about anything except aquatic therapy, or even if it's water aerobics for some people. I think the water is our favorite modality for activity and safe exercise in a lot of patients, especially with progression of weakness where on land activities are really challenging. That buoyancy of the water is really helpful for patients to be able to unweight their limbs, but still move against some resistance. Patients can often get that cardiopulmonary benefit that, the heart rate goes up while they're doing activities in the water that they can't necessarily do on land. So if I can find a way to get a pool approved by insurance for every person, I think that would just be ideal, because access to the water-based services is the biggest challenge. But there are creative ways. So there are, in a lot of communities, warm water pools at local senior centers and all sorts of places. I've had some families that have reached out to local hotels with pools, and during times of low occupancy. Yes, thank you. They do often let patients with various diagnoses use the pool for reduced cost, or whatever is negotiated with that individual location. So that can be a really great resource if there isn't a senior center or warm pool or a physical therapy pool available in your area. In terms of who it's safe for, I would say as long as your physician team doesn't have any concerns about your breathing ability in the water. So because water kind of puts pressure on our body, if breathing on land is hard, being in the water, it can be a little bit more stressful. That doesn't mean that it's an impossibility, but it is something to consider. I'd say almost everyone could do aquatic PT or an aquatic based therapy. So it is our favorite.
Wonderful. The question is, how hard is hard enough? If I work out in the morning, is it okay that I feel fatigued later in the day? And what about if I feel fatigued the next day?
Yeah. So again, you are the expert in you. So what we want is that you are able to work your body, but still have the energy to be yourself. So it may be okay if you feel a little bit wobbly later in the day, or maybe you have a little bit of muscle soreness later in the day. If it's lasting more than one day, that may be a sign that you pushed your body a little bit too hard. If you, at the end of the day, don't have energy to go out with friends or do that thing that you love doing in the evening, you're just a couch potato, then that's also probably too much. So I would start at a shorter duration or less intensity and try to kind of build up to more time or more intensity.
When exercising, is it better or more productive to focus on endurance and length of time or on strength building?
That depends on your goals. So I think both of those are valuable. Often when you're working on building endurance, as part of building endurance, you're also building some strength in your muscles. I think I would focus more on functional activities and functional goals, because I think the activities that you need to do to reach those goals often involve almost kind of a cross training where you're doing some strengthening, but you're also building endurance. And so kind of pulling all of that together is really helpful.
I think this is an advanced stage question. It asks, how long should a myositis patient be engaged in physical therapy? When is it time to let it go?
Yeah, that's a great question. So I, again, as a physical therapist, would argue that there are benefits to physical therapy for anyone at any stage of disease. But again, it comes back to that goal. So what is it that is what is the change or what is most impacting your quality of life or level of independence that's really bugging you on a daily basis? I think, even if you're using a wheelchair and maybe your arms are fairly impacted, there are activities that can still be worked on in physical therapy strategies. And maybe if gaining strength isn't feasible, even having that resource to find new equipment or other supports that may make that specific activity easier and give you that increased independence is useful. If that being said, if you are attending physical therapy and you're not finding a benefit, you're going because you're in kind of a rut or you're used to going, or you got this great relationship, but it's become more of a social hour, you're not really seeing an improvement anymore, then that may be time to take a break and work on that kind of home exercise program in your home environment. You can still hang out with your PT socially, but.
I am a 61-year-old African-American female that was diagnosed with myositis 3 years ago with CKA levels of 20,000. I did not experience any trauma. My doctors feel it was due to cholesterol medication. After 3 years of treatment, my CK levels ranged from 300 to 400. Although I'm better, my legs are always sore and I struggle with certain leg movements. My questions are, will the soreness in my legs always be there? And then number 2, is there a cure for this disease?
Good questions. So I think that soreness piece comes back to kind of the question earlier where, there can be multiple causes of that soreness. Some of those may be, disease related or kind of disease process related. Some of those may be due to activities, doing too much or moving your body in a different way. What's most helpful when you have symptoms like soreness or pain or fatigue is to look for patterns in that symptom. Often patients will say, oh, it's just random, it comes or goes, or it's always here. But if we give them the activity that for the next month, I want you to kind of journal when is it bugging you most? How would you rate it? What did you do right before? Kind of keeping track of that in a systematic, scientific way. We're often able to identify what that source of the soreness or pain or fatigue is, which again, may or may not be specifically related to the diagnosis. And unfortunately, we do not have cures for most of our disorders, but just know that we as a community are moving as fast as we can toward those for everyone. It does take time.
I have polymyositis diagnosed 4 years ago. Should I eat more protein with this condition daily? Should I consider adding the supplement coenzyme Q10? Does that help at all with polymyositis?
Yeah, that's a hard question to answer. So nutrition, dietary changes are questions that we often get from patients. And it's a really hard thing for us to scientifically answer because, again, we are all unique humans and these diagnoses, I guess, manifest differently in each of us because of all of those fun factors that make us uniquely us. So I would say talk with your physician team. So just because it's a supplement or something that is naturally occurring does not mean it's not a medication or it can't impact your body positively or negatively. So I think it is worth trying these things in a monitored fashion. And then again, you are your N of one study, so you know how your body feels regularly. I think with some supervision and oversight, you can trial different medications or supplements as deemed safe by your team, and then see, again, I would journal, keep track of yourself and how you're feeling from day to day to see if you are seeing true changes. So your own clinical trial.
I have DM and I'm 82 years old. How much should my muscles be stressed during exercises?
Good question. Well, I'd say age is irrelevant. So the body can do exercises at any age. It's just how you exercise and do that activity may change over time. I think, again, we use that same paradigm. So we want you to be active. We want your heart rate to be up at a safe level as deemed safe by your local multidisciplinary care team. And we don't want you to be overly fatigued where you're just exhausted and don't have energy to do other things. Finding those activities you enjoy doing and finding ways to build those activities into your daily routine, I think is safe at any age. Again, as deemed appropriate by your multidisciplinary care team.
Absolutely. This says I'm 63 and need a knee replacement. My IBM was diagnosed 1.5 years ago, and I'm probably 3 to 4 years into IBM. Are there any concerns with physical therapy after knee replacement or information that might cause me to be hesitant to have the next replacement, considering my IBM or recommendations for a specific type of therapy post-surgery?
Good question. I'm going to sound like a broken record. It's great to talk to your multidisciplinary care team. I would say in general, having a diagnosis of a neuromuscular disorder does not keep you from having orthopedic surgeries. The way that we, rehab after surgery may be changed based on, the knowledge that you have a diagnosis. For example, we like to reduce any periods of immobilization, which can have a larger impact, as one of our questions was earlier. That period of immobilization can really kind of impact muscle atrophy and those feelings of disease progression. So our team often consults with our orthopedic surgeons to make sure that we're getting patients mobile and active as quickly as possible, but also as safely as possible.
Okay, we have just one question left in the queue. So if you have any questions, please put them in the Q&A at this time. Dr. Alfano, is there any standardized PT form or test criteria so that our personal team can use it to measure useful progress? And how do patients set realistic goals, especially since we're all at different stages?
Great question. So I will answer that first part first. So For better or worse, I'd say there's pros and cons to a standardized PT form. There is not a one-size-fits-all approach for evaluation of patients. So I would challenge your local team to find ways to monitor you that are not just those fun neurologic exams that the docs do, but do involve some functional or patient-reported measures. Often what is feasible within a clinic environment differs. So we don't often say you must do this stair climbing task or you must do this, prolonged walking task, because it's not always feasible. But if there is a way that the clinic can measure you functionally that is meaningful to you, that's what we would suggest. I think regarding setting realistic goals, since you're all at different disease stages, is a great question. I think the discussions that I've had with patients, I think patients are wonderful at setting goals, whether or not you are setting goals. So, when you're going to a clinic and you say, this eating hamburgers is my favorite thing, and this has become so hard, that is a goal that we can work towards. So you want to be able to eat a hamburger as you could before, either in a period of time or with a certain level of independence. I think focusing on those things that are meaningful to you will also help set those realistic goals. I think the harder discussions are when abilities are lost. So I think the most pivotal one where we're having a lot of discussions with patients is that loss of walking. I think regaining a skill, I'm not going to say it hasn't happened, but that's often a harder threshold. So we do like to focus on skills that you have that maybe are challenging that we can work to make easier or give you a higher level of independence, if that makes sense.
Does a burning sensation of the calf muscle mean that you should stop exercising?
Ooh, that's a fun question. Not necessarily, but maybe. I'd say it depends on the intensity of that burn. So I'd say some amount of burn is okay because, as you're moving your muscle, you are, if you're moving it in an anaerobic way, you start to get some of that lactic acid buildup. I'd say the longer you are feeling that burn or the more intense that burn gets, then that's where we're more worried about the impact that burning sensation is having. It's kind of a vaguely specific answer.
So one of our community members asked you to please say hello to Dr. Jerry Mendel for them. So we have that. I have, I guess, one wrap-up question, and then we'll have some final remarks from you, Dr. Alfano. I know a lot of our patients worry about falling, and some of them opt to progress to assistive devices that make them feel safe, sometimes maybe quicker than necessary if they were working toward goals. What do you have to say about that, and how patients progress through the use of assisted devices, when to make those decisions?
Absolutely. So these are important conversations to have, and they're conversations that shouldn't be rushed, and there's not always a right answer for every patient at every given time. So I think going back to that paradigm that it's better to have something and not need it than need something and not have it is what we constantly reiterate. So just because you have a cane or just because you have a walker, or just because you have a wheelchair doesn't mean you have to use it. But when you need it, you need it. And what we often find is I talk about falls a lot with some of my patients. And some of them, every time they come in and they look so bashful because they know they fell twice since the last visit, and we're going to talk about it. But why we are so worried about falls is that injuries can happen, not to state the obvious, but when those injuries happen, often that brings patients off their feet before needed, or it dramatically impacts strength because there's a period of immobility while you're healing, or you can't be as active. And so it's those injuries that often hasten loss of a functional ability rather than use of a device, because we all want to use the most efficient method of movement. We're not going to just sit in a chair if getting across the room on our feet is easier. But when your body needs that because you're tired, or you want to hang out at Disney World with the grandkids, or, whoever, you want to have the energy to have fun. And if you don't have that device, you're just going to be crabby because you're not going to have fun. So we want you to be safe. We want you to enjoy your activities. And I think those devices are great resources and tools that you can use if you need them, and you don't have to use if you don't need them.
Okay. This question asks, is lightweight training and high reps okay?
I'll say in general, yes, but I would work with your local team to make sure that that specific activity is safe for you at any given time.
I have IBM and an 11-year-old titanium hip replacement. Do the muscles react negatively to that implant?
I would say in general, no. So I think what is more impactful is having that implant kind of disrupts, they have to move your body to get that implant in. And so that process does take some rehab and can impact your muscles. But I would expect that, assuming that you're not having acute changes, which could be signs of a variety of things, that in general, those replacements should be well tolerated. If you do have any concerns, so if you've had sudden changes in, redness or inflammation or pain or change in function, or you can't move your hip like you could before, then I would absolutely reach out to your surgeon and team to make sure that everything is still functioning as it should be.
Okay, seeing no additional questions, I'd like to first thank you, Dr. Alfano, for taking your time to be here with us tonight, for opening your office door to our patient community virtually, both nationally and internationally. We cannot thank you enough. Do you have any closing thoughts or sentiments you'd like to share with our patient and care partner community?
I would just say in general, I hope that you learn as much from us as we learn from you. So I think I enjoy spending time with patients in clinic and having conversations, even if they seem tangential or irrelevant to the clinic visit. I think the patient community is adaptive and creative and amazing. And so, the things you're telling me that you have created in your home that make this or that easier, or activities that you've tried, we try to pass on to the next patient. So, don't hesitate to share or even overshare, because I think we love those conversations. So don't be shy. Keep asking questions and keep sharing all of your great innovations.
Thank you so much, Dr. Alfano. I just would like to take the opportunity to wish all of those in the Myositis Association's community, our family, a very happy holiday season as you look, if you should celebrate in the coming weeks. On this past Tuesday, hosted by our own Chevelle Montgomery, we held an empowerment clinic webinar all about managing your mental health throughout the holiday season. And we'll make that recording available. We want to make sure that you all have the best opportunity to have the best rest of November and December possible. For December, our Ask the Doc session will be hosted by the Myositis Association with our own medical advisory board member, Dr. Marilee Needham. And we look forward to having you join us for that session on December 15th. Again, I am Chrissy Thornton for the Myositis Association, and we thank you for joining us. Good night.